Good afternoon, everyone. We have a very full hour planned, so I'm trying to start as close to on time as possible. And welcome to our session on maternal and neonatal health in a burning world, and I think an appropriately dramatic title. I'm Dave Rippon. I'm Chief Science Officer and oversee the infectious disease and climate programs at Clinton Health Access Initiative. I'll just give a few remarks to set things up and then turn this over to some really fantastic speakers, and then we'll end with a panel session. So here we are, 2 days after the first ever health day at a climate meeting. And I had the absolute privilege of sitting in a meeting with a few ministers of health from low and middle income countries and a set of donors. And one of the ministers, I thought, really summarized it quite well. We can't just look at the climate and health issue as a financial and physical crisis. We have to remember our morality and our ethics here. You know, a child who's 1 year old, a mother who's 20 years old, how much have they truly contributed to the climate change which is threatening their lives? It's fundamentally unjust that we are seeing people who are most vulnerable to the effects of heat and climate change who are bearing the brunt of health impact. So on behalf of CHAI, the London School for Hygiene and Tropical Medicine, and Human Rights Watch, we've worked together to put on this event, first initiated by the Arsht Rock Resilience Center, which is part of the Atlantic Council. We're so grateful to our hosts here in the Resilience Hub for hosting us. I think we've all been working collectively in different ways to bring more attention to the research and data around the ways that extreme heat is worsening maternal health and driving those just inequities that we see between who does have a healthy pregnancy and who doesn't. We are excited to see so much attention here at COP to this critical program, especially in the conference with the first health day ever. There's many events, for example, just on this very topic of maternal and child health and extreme weather and its impact on health. But now that we are aware of the situation, the fundamental question I hope we tackle today is, what are we going to do about it? We want to use this event as a call to action and to compare notes and figure out where we can join hands and work together for concrete action to improve and protect maternal and newborn health, and provide some insights into the first steps that governments and organizations around the world are taking to achieve this outcome. We want to keep justice and equity at the center of this discussion as we talk about the emerging policy and actions that we need to take. So I'm going to turn this over to our speakers. We have three. None of them are physically here. I'm still getting used to a world of Zoom. But first, we're going to hear from Rafia Rauf, who is the National Coordinator of the White Ribbon Alliance Pakistan chapter. Rafia is a development professional with over 2 decades of experience working in various domains, including project management, leadership, grants management, and organizational transformation. She's committed to advancing the critical global and community causes for this and has worked in collaboration with the government of Pakistan on these issues. So with that, I'll turn it over to our recording of Rafia, which I'm assured will start in mere seconds.
Thank you, David, and hello, everyone. And my apologies, but I'll have to turn my camera off because the connectivity at my end is not very strong. So you can kind of like either hear me or see me, and I think that you better hear me. Okay, so sorry about that. All right. So I'm here to share with you today the findings of a qualitative research study that we conducted to explore the intersecting link between maternal health and extreme heat. However, before I do that, I want to give you a quick and short glimpse into what maternal and newborn health is like in Pakistan. In terms of both maternal and neonatal mortality, we are not just lagging behind the SDG targets, but rather our rates are higher than all our neighboring countries. Especially in terms of newborns, 63% of children under 5 who die in Pakistan are newborns. Now, Adelaide has just talked about why and how pregnant people are more biologically vulnerable to extreme heat. So just add that to the existing equation, and you can well imagine that the figures that we have here are likely to get worse rather than better in the coming years as periods of extreme heat increase in frequency and intensity. Now, with this in perspective, we wanted to explore as to how pregnant women and new mothers are dealing with this challenge, and also what can be done to help them address it. So we selected district Shikarpur in Sindh, where average temperature during summers ranges from 36 to 38 degrees Celsius, and we conducted in-depth interviews of 16 women, 8 pregnant and 8 lactating. Now, in the coming pages, I will be using their words to bring their experience of extreme heat to you. First of all women we interacted with reported suffering from dehydration, nausea, vomiting, severe headaches, fatigue, and lethargy during periods of prolonged heat. This was like a constant complaint. Then, extreme heat or periods of prolonged heat also appear to add to, compound, and further aggravate any existing health issue that these women have. Also, remember that heat affects all. So if they are getting ill, so are other people in the family. And as is generally the case everywhere, it is always the women who end up bearing the burden of care. Then there are the atomic consequences. In Pakistan, around 65% of the population is affiliated with agriculture, either directly or indirectly. So with extreme heat comes low productivity, and that affects livelihood. To make up for that, women work. And in rural areas, their work essentially involves working in the fields. And during periods of extreme heat, it means either working and getting a sunstroke or not working and consequently going hungry. Everywhere, women do a lot of unpaid labor. It kind of like counts as being a woman. But doing these things gets challenging in heat. Imagine a woman in a rural setting who has to cook in front of an open fire during extreme, or take care of livestock, or carry water from afar in great quantities because the entire family's intake of water increases during heat, or take care of young children who are also getting repeatedly ill because of the increased heat. And when you imagine all this, also imagine that that woman is pregnant. So what is that pregnant woman feeling? Well, first of all, they all hated being pregnant during summers and wished that they could change the months of their pregnancy. Also, they were stressed about the baby they were carrying because they experienced reduced fetal movement during heat. Whereas women who were breastfeeding reported that both their sleep and food intake was compromised during heat, and this in turn made breastfeeding very challenging, which ultimately adversely affected the baby's health. Now, amidst all this, what about the mental health and well-being of these women? And what we found reported was a constant and all-pervasive feeling of unhappiness caused by all the things that heat was worsening, like sleep patterns, food and nutrition, working conditions, livelihood, children's health. Most importantly, there was despair over the prospect of an even hotter future. Well, so what are these women doing to handle this? Well, first and foremost, lots of showers, like 5 to 7 times in a day. This is how hot it gets, especially when those living in rural areas end up facing 12 to 15 hours of daily power outages. Then there's a reliance on solar panels, but these are very simple apparatus with no batteries, so they run only during daytime. At night, they sleep in the open courtyard. Another thing that we found was a tendency in these women to distract themselves from the ongoing situation, either by getting busy or going to their neighbors and gossiping, and even spending time alone by going to cool places that they could access. For mobility, for women in rural areas can be quite a challenge. Now, when interviewing these women, we also tried to explore as to what kind of interventions will they find helpful. Well, some of them were obvious, like they wanted uninterrupted supply of electricity or affordable solar energy units. They also asked for information that would better equip them for handling these periods of heat. Access to cooling places for women, just like for men, was also pointed out. Interestingly, removal of harmful cultural practices was particularly underlined, one being that of chilla, in which a woman, upon giving birth, is stopped from drinking or taking showers in cold water for around 40 days. This is practiced in certain rural areas of Pakistan. Now, these were their identified measures, but what can we do to make things easier for them? Well, first and foremost, it is high time that countries with high emissions realize that it is their human rights obligation to address harms to marginalized populations, either by curbing greenhouse gas emissions or by providing resources for addressing their needs. Then, measurable steps need to be taken at all levels, national and international, for including maternal and newborn health in climate adaptation, planning, and resourcing. Research for protecting maternal and newborn health in low-income countries from extreme heat, and sharing learnings from pilot interventions carried out for addressing the challenges caused by extreme heat and other climate harms, for that matter, to maternal and newborn health also needs to be prioritized. So basically, this is it from my side, and I hope that you found the findings of the study as interesting and as fascinating and as eye-opening as we all did. Thank you so much for this.
Thank you so much for that. I've also just been informed that we actually have a unique aspect to this meeting. We have a cartoonist who is capturing the essence of the discussion that we're having today online. And in the last 2 minutes of this session, we'll get to see what that looks like. I'd now like to turn to Adelaide Lusambili from the Africa International University. Dr. Lusambili is an associate professor at the Environmental Health and Governance Center, bringing extensive experience as a health system researcher in maternal, newborn, and child health, as well as an educator. Over the past 4 years, she's dedicated her research efforts to studying the impact of heat on maternal and neonatal health. Adelaide?
Thank you. Yeah. I can't read my slide. Can they be made in a tray, please? Okay, good morning, everyone. Thank you for listening. I'll be presenting on behalf of the Climate, Heat, and Maternal Neonatal Health in Africa. And this is a program, this is a project we've been working on for the last 4 years on the east coast of Kenya. Next slide, please. So we all know that epidemiological data demonstrate that heat has a detrimental impact on maternal health. It heightens the risk of adverse birth outcomes, and heat is recognized as a risk factor for both stillbirth and preterm birth. Heat is also recognized as a risk factor and is associated with increased likelihood of birth defects, hypertension, preeclampsia, and gestational diabetes. Also, we have compelling research that indicates that during periods of elevated temperatures, pregnant women are often experience anxiety, leading to a reduced likelihood of attending antenatal care appointments. In addition, we have studies that have highlighted that postpartum women are less inclined to utilize bed nets, participate in postnatal care sessions, and are more likely to suspend or supplement breastfeeding. Slide 2, please. So our Jamna qualitative study on the east coast of Africa highlighted some of the consequences of extreme heat on women. We found that women's daily workload increased during high temperatures. in coastal Kenya, where we conducted our research, like many parts of Africa, women continue to do heavy workload and are expected to do so in early days of postpartum. So we know that heavy workload in the heat leads to exhaustion and is perceived to cause miscarriage and C-sections due to the inability of women to push their babies. So after our findings, we co-designed with the community members to come up with interventions that are appropriate for reducing the adverse effect of heat on women during pregnancy and postpartum. So we focused on pregnant women on postpartum, including their household, key influencers, and other key leaders to educate them on the importance of heat effects on women so that they could come up with solutions to help women during the heat. Slide 3. So our intervention was a behavior change intervention, and we aimed at mobilizing women and the community to support, to come up with protective behaviors that can reduce the harms of heat exposure on pregnant and postpartum women and neonates. So we focused on two components. The first one was social support for pregnant women and postpartum women. And the second component was to increase knowledge, information, and education about the adverse effects of heat on women during pregnancy and postpartum. So some of the components we focused on was the importance of frequent and exclusive breastfeeding. We also educated the community on the need to keep hydration during pregnancy and postpartum. And besides teaching about the dangers of heat, we actually wanted the community to shift some of the social, cultural, behavioral practices that are harmful to women in periods of extreme heat. For instance, some of the harmful behaviors were overbundling or overlayering of children when it's hot, or working with newborns in the heat. So we used a system approach to mobilize the community so that everyone could come together and begin to support women. So we had 3 phases. Phase 1, we developed videos and pictures depicting heavy workload for women, which we used in our phase 2 to educate the community, the male spouses, the mothers-in-law, and the key leaders at the ministries and in the community so that they can be well educated about the dangers of heat and begin to support women. And then later on, we mobilize the whole community to teach them about the dangers of heat, as I've explained, so that they can be better informed to help pregnant women and postpartum women. Next slide. So our intervention outcomes were varied. First of all, we had targeted the male spouses, and we had targeted the mother-in-laws and the whole community by using a system approach. Towards the end of our intervention, we got reports that there was increased knowledge on the dangers of heat. And because knowledge had increased, the community now began to put protective measures in place to support women. For instance, in this community where we collected our data, it's predominantly patriarchal. But after we educated the male spouses and the leaders who were predominantly men, they went back to the community and passed on the message, and there was an improved help for women during pregnancy and postpartum. Also, women and the community at large reported increased improvement in knowledge about the dangers of heat and the need to put protective measures in place so that they can support mothers and their newborn babies, as well as put up protective measures in the community. But this also had adverse effect on the men who are the decision makers. For instance, men who stepped out to help women with household chores during pregnancy were stigmatized by their peers for taking up roles that were traditionally meant for women. So our intervention, although it worked, but it had detrimental impact on the men who took up these roles. So this also had implication in that we found that in homes where men didn't work, they got more help as opposed to where men were in white-collar jobs. And some women actually reported having improved their health and having had enough time, now having more time to breastfeed their children as opposed to before when men were not supportive. Next slide. So from our intervention, we conclude that community approaches to supporting women are visible, but shifts in behavior change can take a long time. And it's also visible when we train the community members and the elders and all the key decision makers to help women and include these messages in their daily work. We can have remarkable changes in such a patriarchal community. But however, research is still needed on whether sustainability requires repeated training. And largely, we recommend that future heat adaptation interventions focused on maternal and neonatal health should consider factors such as employment, age, gender roles, and support networks. So to conclude, behavior change is visible. However, it requires a lot of time in these communities where these communities that have experienced heat for extended period of time and heat has been normalized as part of their daily life. Then it's really difficult for them to discern whether it is climate change or it's drought or it's heat. So such a behaviors must be continuous and must take a long time, and messaging must just continue for many times before we can see incremental changes. Thank you.
Thank you so much. And for our final speaker before we move to the panel, I'll introduce Dr. Elizabeth Leonard, who is with the Clinton Health Access Initiative in South Africa. Elizabeth works across congenital syphilis, MNCH, and solar energy programs. And so over to you, Elizabeth.
Thank you, Dave. Good afternoon, everyone. Today, I will be taking you through the adaptation innovation that we are developing, the Smart Climate Health Early Warning System. The warning system is targeted at individuals in the perinatal period because, as the previous speakers highlighted, pregnant people, developing fetuses, and newborns display unique biological vulnerabilities to the climate crisis. Early warning systems are an integral part of a resilient health system, particularly when considering our current reality where climate change has increased the frequency and severity of extreme weather events and disease outbreaks. In South Africa, we have existing early warning systems that do play a crucial role in identifying potential public health risks. They are operated by the National Institute for Communicable Diseases and the South African Weather Service. During the 2022 National Strategic Risk Assessment, one of the capacity gaps identified for the country was the ineffective dissemination of information from early warning systems to the community level. There needs to be an enhancement of existing systems towards adopting a more integrated intersectoral approach that better links health and weather systems. There also is a need to improve the dissemination of information by rapidly targeting vulnerable individuals who are in exposure pathways. To aid in addressing the capacity gap, we are in the process of establishing a smart climate health early warning system. Interoperability and sustainability are core principles of the system. Therefore, existing South African Weather Service and National Department of Health resources and expertise will be leveraged and enhanced to enable usability and long-term sustainability. The system will leverage the National Department of Health's mHealth platform, MomConnect. MomConnect provides pregnant people and new mothers with stage-based health promotion messaging directly to their mobile phones. MomConnect has gained impressive traction in South Africa, with 95% of public clinics having registered mothers, the all-time MomConnect users sitting at over 4 million, and a very high user satisfaction rate. The 3 data points from the MomConnect database enabling the targeted dissemination of early warning messaging are approximate geolocations, pregnancy stage or newborn age, and mothers' cell phone numbers. The second pillar of the Smart Climate Health Early Warning System is the well-established South African Weather Services forecasting system. From the Weather Service data sets, we will use the data points that are linked to adverse health outcomes following either individual or combined exposure during the perinatal period. These are temperature, relative humidity, air quality, rainfall, and wind speed. The South African Weather Service and MomConnect are well-established entities, which the Smart Climate Health Early Warning System will enhance by integrating health and weather service data sets to enable the accurate prediction of weather events that will negatively impact perinatal health. A key aspect of the system is the development of thresholds. Often the thresholds in weather systems do not have a biological or a health component. Take the declaration of a heat wave as an example. There is no universal definition of when to declare one. The South African Weather Service definition compares forecasts to historic temperature to declare a heat wave. But as our planet continues to warm, the thresholds to declare a heat wave will increase, but the human body's ability to cope with excessive heat will not. Thresholds need to consider the likelihood that a climate-related event, for example, a heat wave, high levels of air pollution, or rainfall, will have a health impact. Therefore, our smart early warning system will incorporate evidence-based perinatal climate health literature into the Weather Services forecasting systems. The geographic area crossing a defined climate health threshold will trigger a text message alert, which will be sent through the MomConnect platform to pregnant persons and mothers in exposure pathways. The messaging will be customized to pregnancy stage or newborn age and will include co-created adaptation measures that incorporate local knowledge and highlight when to go to a health facility. The Smart Climate Health Early Warning System is a movement towards an agile, impactful, community-centered system. mHealth interventions in perinatal care have demonstrated significant value in improving maternal and child health outcomes. We anticipate that our intervention will follow suit, mitigating adverse health outcomes by empowering mothers to make well-informed decisions about their health and their newborn's welfare. Importantly, at the core of the intervention is interoperability. The Smart Early Warning System builds on existing structures to ensure low costs, high levels of acceptability, and sustained use. The intervention's potential extends beyond maternal health in South Africa. The concept is transferable to other countries in the region that have established maternal mHealth platforms. As a way forward for the Smart Climate Health Early Warning System, additional resources need to be secured to continuous development. While investing in adaptation interventions such as ours are vital, we also need to invest in mitigation. Fossil fuels harm human health. There needs to be a just transition away from fossil fuels to ensure that health inequities are not further exacerbated. Thank you for listening.
All right, for that, thank you so much. Those were three really outstanding talks. I'd like next to invite our panel to come up. I'll introduce you briefly, but please come take your seats. I apologize you're not all sitting right next to each other. We've arranged the room around that post that's in the middle so everyone can see each other. So on our panel today, we will have please come up and join us. We're going to be hearing from Dr. Antonis Kolomanakis, Technical Officer looking at climate and health in the WHO Africa region. We have Dr. Angela Bislieri, who is with UNFPA, Technical Lead on Climate Action. We have Dr. Revtai Falki, Global Director of Health and Nutrition with Save the Children International. And lastly, we have Dr. Amadul Kabir, who is the ADG of Planning and Development in the Directorate General of the Director General Health in health services in Dhaka, Bangladesh. Thank you. Thank you all for joining us. I think what I'm going to do is prompt you all with some questions, but then ask you to take 3 minutes each to talk about what you think is most important in this area. The one thing I would ask you all to address is what are you and your agencies doing, as well as thinking about what we need to see change over the next 10 years. What's the role of UN agencies, governments, and other stakeholders like NGOs to include environmental determinants of health and policy for MNCH? Or in what ways should we be breaking out of our old patterns of business as usual? So maybe I can just go in the order we're seated and start with... I'm sorry.
Use my name, Antonis.
Antonis. Thank you. Antonis, so please.
Thank you so much. I'm really honored to be representing our organization in this very important discussion. And I would kindly like to invite you to follow me a bit in a reverse thinking process. One of the most important mantras we have at WHO is leaving no one behind. Now, let's, of course, this is leaving no one behind in terms of health, of access to health. Now, let's reverse the thinking and let's consider instead of health, climate change. So climate change is something that is leaving no one behind. Let's take this one step further. Leaving no one behind is a mantra that wants to really indicate the importance of equality. And indeed, even in this paradoxical argument, we have a huge inequality because climate change is indeed leaving no one behind, but in a very unequal way. So it is the vulnerable population, both in terms of social vulnerabilities, but as well we know by scientific evidence how the vulnerability of women and children and pregnant women in particular in regard to health outcomes like malaria, like the exposure to diarrheal diseases is affecting particularly, is causing this huge inequality to the population. So all these paradoxes, the reason why we are actually having a huge responsibility of being following the negotiation processes, of being following the climate, the climate agenda. And I would like to highlight also in regard to the questions that the chair posed, two milestones in terms of action towards addressing those very important issues. The first one is what we call the launch of a program, which is called the COP26 Health Program. This has actually been a call to member states to engage, to come together and advocate on the importance that states indicate in regard to the effects of health. Again, I would like to highlight that issues like air pollution, issues like asthma and similar diseases, but as well as difficulty having access to healthcare facilities is very much related to specific population groups, which are the groups which are studying in this discussion today. And for this reason, we have launched this call for action, which translates into specific concrete measures that we encourage countries, we support countries in the response. So some of these are, for example, the conduct of vulnerability and adaptation assessment. And this is really important for the state actors to make sure that there is a coherent risk mapping of those specific diseases in terms of populations. And so I would like to end this first level of statement by saying that this is all being monitored now through the ATTACH, which is the Alliance for Transformative Action on Climate Change and Health. This is an open platform. This is a call for common action because I don't think we have the luxury to be secluded, to be siloed anymore. And this is really the way to which we see this as an inclusive, as a holistic approach to address these important issues.
Thank you so much. Revati, would you like to go next?
Yeah, so I would speak from our organization's perspective. We have two priorities. The first one is, of course, elevating the voices, having meaningful inclusion of groups, and of course, our focus is on maternal and child health here. But of course, we advocate for vulnerable groups in general, with a special focus on children, given that there are almost 2.2 billion of them in the world. Yeah, children and adolescents. So the first is to elevate the voices of these groups into conversations like these, into policy making, into programmatic priorities that are being set at the global level, such as here, at the regional level, at the national level, but also at the subnational level, because we know that we are advocating for locally led adaptation. So all the decisions that are happening at that level, the voices of these groups have to be meaningfully included and listened to. So not tokenistic inclusion of, vulnerable groups such as children, women, indigenous groups, and all of that, but really having the frameworks and the operational roadmaps that will actually give us that quantification of what have we achieved. And then as a civil society organization, we also play a role of auditing. That, that once all these ambitions are or commitments are announced, are we following up on them? So that is another role that, organizations like mine would play. The second bit is, of course, financing. And I know that we heard a lot on day one and day two around financing, and we're not just calling for additional finance, but we're also calling for responsible and equitable allocation of the funding. So just having additional goals agreed in the loss and damages fund would not be enough from our perspective. It's also about the allocation that comes within those. So if we look at, Save the Children had recently done a report on multilateral fundings over the last 20 years. And 5 of the major multilaterals, their funding, almost I think 560 projects that were assessed. And just 2.4% of that funding was allocated to child responsive programming. So it's a huge gap. Health itself, we hear the number very often, that less than 1% of the adaptation fund goes for health, but then even lesser than that is going for children's health. So these are our two main priorities. And then I'll end with, so what are we doing about it, right? So these are our main policy advocacy asks, these two. And then in terms of the programmatic, of course, we have health, nutrition, WASH programs in almost 66 countries. So we're trying to mainstream climate sensitive programming in everything we do for health, nutrition, WASH. That's the first thing. The second thing, in terms of risk assessments. So we are taking a systems-based approach, and we heard a lot about that from the previous two speakers, a systems-based approach for risk assessment, but also for risk management. So that, we are looking at health, nutrition, WASH, but also where opportunities present, adding child protection, education, basic needs of these populations, so that you're not again siloing the programs that we do. And I'll end with probably the biggest and the strongest thing that we have achieved, in our opinion, from our perspective. We're the only GCF accredited agency with a child rights focus. And we're very pleased to say that we've recently signed the first ever health-focused project in Laos. I don't know how many of you have heard about this. We've been talking about this everywhere because we're really proud about that. And of course, we're doing that together with the WHO and with other partners. But we have 3 other projects that are in pipeline from now until then. So that's a very concrete step. And it has been a painful process of not just getting the accreditation, but getting the proposals through. Thank you.
Congratulations. That's a remarkable milestone. Amadul?
Thank you, moderator, and my other panelists, and the brilliant presentation we learned. The 3 presentation was very good. So if I just look at the headline you have said, there is a birth in a burning world. I will be talking in context of Bangladesh, what we'll be doing. That is the things, but I want to focus on the issues, what is being addressed today. Really, this is a very important agenda which has been discussed today. The birth in a burning world, the world is burning and the temperature is rising. we are trying to adjusting and mitigating these issues. Though, like Bangladesh and other countries, their contribution in the burning world is very less, but we are the sufferer of this. So we have got two issues are there. We need to talk about the let not the world burn. That is the main thing where we need to work. We are actually working on an ad hoc basis and at trying to mitigate the problem rather than adjusting the problem. We will have to focus on the mitigation. In terms of Bangladesh, where the contribution of burning is there, we'll try to reduce that in our health and national plan, adaptation plan for climate has been addressed like that, so that we will not contribute anything for the burning of this world. That would be the main contribution throughout the globe. We are living in a global village. Whatever I act here, globally that will be affected. That should be the commitment throughout the world. And the WHO should take the leadership to make the people, policy level understand, not to burn the world. That should be the main issues. Whenever there is a burning, you have to cool down the world. What you do for the cooling down, you have to burn the fossil fuel. What it means, fossil fuels means, the more fossil fuel you burn, as a human being and earth, there are no difference. As all the human being harboring here, you are harboring 10,000 species of microorganism in your body. That is nearly 40% of your body weight, living microorganism, everybody. And the earth is having nearly 8.7 million species. And the earth and human body is no difference, composed of carbon and hydrogen. So whenever you burn the fossil, it is producing carbon and hydrogen. Ultimately, it is destroying the ozone layer and the heating is more. So this is in terms of globally, we need to act. And the microscopic things what we are doing, that can just, some adjustment could be there, but it will not really halt the process of burning the world. This will be continuing and the more and more will be continuing. So that needs to be focused definitely globally. Now in terms of Bangladesh, what we can do, in our fifth sector program, we have addressed many of the issues and we are approaching a One Health approach. So that environment, our agriculture, our electrification, to reduce the fossil fuel burning, we're going to make solarization of the electric side so that renewable energy can be produced. And the bio-waste, which is producing the hospital, that has to be addressed properly so that they will not pollute the climate and ultimately leading us to a high temperature and the subsequent effect on the pregnant mother and others. Some of the areas in Bangladesh is highly vulnerable, like the Bay of Bengal. You know, Bangladesh is a delta zone, which is being produced from some 3 rivers. These are the Jamuna, Brahmaputra, and other rivers, and this land is very, very vulnerable and not that high level from the sea level. And you know, the 2023, this year was the highest recorded temperature in Bangladesh also as well. So the world is heating there. So we made what in our fifth sector program, in all the operation plan, we kept climate resilience health systems, training for the doctors, community people, midwives, and others, how to address these issues. And the mother's dressing code and other, keeping all these etiquette normally when there is a high temperature, how to stay there. And most of the vulnerable people is staying in the teen house, which is really heating chamber as well. We are trying to put them some color so that cannot produce much heat. This is another approach. We want to make it cool somehow, adjusting all these issues. I must acknowledge the support provided by the UNFPA, Save the Children, other UN agency working in Bangladesh. They are doing a lot in cooperation with the sector program in Bangladesh. I appreciate SAVE and others activities, UNEP and others, those who are working. I think altogether we can adjust, mitigate some of the issues, but we need to act on the broad aspect to reduce the heat of the world. That is the most concerning issue, I think. Thank you very much for giving me the privilege to talk to you in this August gathering. Ladies and gentlemen, thank you very much for listening. Thank you.
Thank you so much. And Angela.
Thank you. So I think I just want to add, maybe built on the conversation. I think one of the aspects is important to continue to work on is the advocacy at all levels and making sure we work together. I think if you reflect back 4 years ago, I think we had one session at COP on SRHR, maternal health issues. Now there are a full program. We have a health program. We have ministers of health. We have more sector. I think we should congratulate ourselves for the work we have done so far. But I think at the country level, so I'm sitting on the Eastern Southern Africa Regional Office, and we're working quite a lot with the UNCT. Of course, we need to work with other agencies on the support of the NDC process. And what we're trying to do is trying to support that there are at least the language of SRHR maternal health is in there. And we did a series of review with Queen Mary University with support of IDRC over the last 3 years, so fantastic piece of work. And that gave us the baseline and also an entry point on how to work in country. And what we found in the context of maternal health is that only 23 countries of the 119 that we review had a mention of maternal health in the NDC. Now, the NDC is not an adaptation document, but still give you an articulation on how the country is thinking about their climate action. And within those 23, only 11 articulated or mentioned some form of intervention into the health sector or a community response. So there was different type. So we're doing some work at that level. We coordinate with other UN agencies. We are part of in Eastern Southern Africa, of the UNDC network, so the agency that are supporting government in the development of the NDC. So we have done some kind of practical work there. At the interagency level, also, another gap is the integration of our issues in preparedness plan. And we had another project working on reviewing and harmonizing vulnerability assessment tools for preparedness setting. And to our shock, we had a list of 110 different assessments for maternal and sexual reproductive health that the various agencies, NGO are using. And so the project was done together with UNAIDS, WHO, UNICEF, and the idea was to try to harmonize, to come up with an harmonization. And we worked we did, I think, 5 pilots, and was really try to work on the nexus. So how do we work better with the DRR agency, how we created that kind of understanding. And there are a number of stakeholders. And that kind of assessment made it very clear how these processes are different in different countries and how the coordination mechanism is not standard, and it's difficult to there is different actors operating at different levels. So there's a lot of work that needs to be done there. So capacity, collaboration is important. Another gap I feel that we need to mention is also how we ensure inclusivity on the design of intervention. What we have seen from the research today, that a lot of the response is you need to understand how climate impact is perceived on the community, and so what are the intervention. In the case of Bangladesh, for example, is research about the salinity level and the impact on pregnancy that had informed the training of nurse and doctors. So is the interlink, the understanding of research, community research, engagement of those impact at various levels. And so we are starting soon another project with the Africa Development Bank. So we managed to get some funding, climate funding. As part of that project, we are training stakeholders at different levels. And then we have some kind of, let's say, a pilot part of the project where we are trying to engage different part of the community to find solutions specifically for those issues through engagement of the human-centered design approach. So we will have to see. We'll being quite experimental part of but those I think are what are missing. So the voices at different level, coordination. So coordinate, work together, and at different level, and communication, I think that's important.
Thank you so much. We have a couple of minutes before we'll hear from our cartoonist. Maybe I can pose a question to you. I am absolutely thrilled to hear how specifically we're focused on action we can take now and what we're doing, as opposed to talking about studying the problem and understanding it. And yet, I feel that I've been in meetings with many donors who, when presented with the enormity of the climate and health interface area, tend to start talking about studying and prioritizing. I'm reminded of a statement the Minister of Health from Malawi made, and she said, if you're walking down the street with a pail of water and you see a house on fire, you use the water. My house is on fire. And I think we're hearing the house is on fire, not just temperature and heat-wise, but figuratively as well. So my question for anyone who wants to respond is, what are the most important responses? And we've heard a few today, from passive, improving passive cooling to wash access and a number of other items. What would you highlight to donors today? We need resource to do right now. No further study necessary. It's just time to act.
Think yeah, I think from the response side, right, I would say that scaling up the known solutions that we have, because right now we know what we can do from a maternal and child health perspective. We know what works. We know that we have to do it at scale. We know that majority of the burdens that we see, whether it's infectious diseases in children, whether it's all the climate sensitive diseases, the interventions for them, 90% of that can be delivered at the primary healthcare level. So, I would come back to what Antonis, you started, that yes, while new evidence becomes available to us and while we put the structures in place for either access to finance or, all the other conversations can continue. But what we can do now is really take the universal health coverage discussions like on a war front, I would say, probably the wrong word, but I think I'm conveying the feelings. Prioritize that, scale the known interventions, and more than just scaling up, the evidence generation. That, how are these interventions working at scale from a climate perspective, and then kind of making that information available to everybody.
I would like to add a very short point. Totally agree with Revati. I also think it's really important to make sure that there is clear political positioning on the importance of this very simple argument that the climate crisis is a health crisis. Because if we don't see this translated into the text that we are all here for, the negotiations text, this will not open the stream, the channeling for more financing to come. We have been developing climate and health principles, and we are also very glad to have announced this development of principles with the Global Fund, with the Green Climate Fund, with the Rockefeller Foundation. Save the Children is an excellent partner, but we need to see this translated to political commitments. And that is also a key role we have to play in collaboration with all the wider community.
Thank you so much. I want to take this time while we now shift. I'm sorry. Do you want a last point?
My last point is to say that climate is affecting everyone. There are some groups that might be disproportionately impacted, but everyone is affected. And I think the sense of ownership is important in terms of thinking about the action, there is importance to have an awareness that climate affecting. So the community awareness of impact. We have seen, like today, how the project is really highlighting how community needs to know that heat is affecting us, and that has to be kind of reflected at all levels. So that's the message.
Thank you so much. So I'm going to turn it to our cartoonist in a moment, but first I just want to express my deep felt appreciation for our outstanding speakers and panelists here today. Thank you very much for your participation. And just as we shift, I am also thrilled, given the topic of this meeting, to see a young member of the next generation in the audience. He is the reason we are talking about this today. So maybe we can turn this over to Rohan to show us what he has created.
Hi, everyone. Firstly, my congratulations to all the speakers for the terrific inputs and for mincing no words with your presentations and speeches. I won't take long. Here are the 4 cartoons that I've managed to create live during listening to you all. For the sake of keeping things short and swift, I'll read the cartoons out to you. Insured illnesses this way. Climate illnesses, please wait in the queue. The next one. I can't tell if the kick was from the baby or from another climate-related complication. The third one. Ma, how is it that even though climate change is causing preterm deliveries, climate action is never delivered preterm? And here's the final one. If only climate negotiations were as intersectional as our vulnerabilities. Thank you. If you all can let me know which ones out of the drafts you prefer, I'll be furnishing them and keeping them available for your publications, your presentations, and pitches. Thanks.
Thank you so much, and thank you to everyone for coming and joining us here today. I hope you have a healthy and productive, most importantly, COP.